Hello, and welcome to this month's Simon Says Expert Series. I'm Dr. Nasser Hanna. I'm the Tom and Julie Wood Family Foundation Professor of Lung Cancer Research and the Chair of End Lung Cancer Now. June is Men's Health Month. And so today we are going to be speaking about the cancers that most affect men, along with the prevention and screening steps you can take to keep yourself and your loved ones healthy. Joining me today is Dr. Thomas Imperiale, who is a distinguished professor and the Lawrence Lumang Professor of Gastroenterology and Hepatology at the IU School of Medicine. Welcome, Dr. Imperiale.
Thank you, Dr. Hanna. Happy to be here.
Well, I'm really excited to join you in this conversation, and we're going to be focused primarily on men's health. And as we know, cancer is very prevalent in men. It is a common cause of morbidity and mortality. And the cancers that are most common in men are lung cancer, colorectal cancer, and prostate cancer. I know you have been a passionate advocate and researcher in cancer prevention and early detection, particularly as it relates to colorectal cancer. I'd like to start off by asking you to tell us your why. Why is this topic so important to you? Can you kind of take us a little bit through your journey as a physician and lead us to why this matters?
Well, I think, with it being the number two cancer killer in men and women combined, I think that says it all right there, and knowing that we've got so many tests and then understanding that using those tests can help decrease the incidence and the mortality from the disease just makes it very compelling.
And so let's talk about what can people do to reduce their likelihood of getting colon cancer?
Yeah, it's a great question. So we'll split prevention up into primary prevention and then secondary prevention. So primary prevention means you're doing things before you even get screened for the disease. And those are going to be lifestyle decisions that you make. So these are the toughest things to implement and maintain. So having a healthy diet, meaning that you favor fruits, vegetables, and grains, and you favor fish and chicken as sources of protein over red meat. So that's one aspect of the diet. So that's what you eat, what you drink. So limiting alcohol intake. In the 20 years that I've been here, or 20 years or so, alcohol has done a 180-degree turn. 20, 25 years ago, we were telling our patients, so having a drink a day is okay for women, having 2 drinks a day for men is okay. People thought it thinned your blood, it had to be good for you. It turns out that was all incorrect. So, but it's so ingrained in our society that there's just a lot of signals that we get that encourage us to drink alcohol. Minimizing alcohol intake is something you can do for primary prevention. So it's what you eat, what you drink. Limiting your alcohol intake to 3 servings a week or none will reduce your chances of getting not just colon cancer, but other cancers that are alcohol affiliated, and there are many. How you live your life. So how much you move will also help prevent colon cancer. People who are active physically have a lower risk of colon cancer, and that applies to moderate exercise and vigorous exercise. So following the national recommendations for getting in so many minutes a week, I think it's like 200 or so, of at least moderate exercise will further help reduce your risk. And all that's targeted to your maintaining a healthy body weight. If you can keep your BMI less than 25, or maybe 26, right around there. We're not exactly sure what the optimal cut point is. That too is associated with a lower risk of colon cancer. And lastly, and perhaps most importantly, and often not appreciated enough, and a cause of many cancer deaths in this country, cigarette smoking, tobacco use. Just don't do it. They just raised the taxes on a pack of cigarettes in Indiana back on July 1st. I think it went up $2 a pack now. I don't know what it costs, but whatever it costs, it's just not worth it. So those are the things you can do for primary prevention. So to reduce your risk of ever developing colon cancer. For secondary prevention, when the time is right, you get screened for colon cancer. That does not necessarily equate to having a colonoscopy, but to get one of the recommended screening tests, one of the tests for which there's reasonable evidence of a benefit for men and women.
Yep. And I would definitely want to dive into that a little bit, quite a bit, but I want to dive into the things that you've already said to begin with. So, when you eat red meat, when you have fewer grains and you have less fiber and less fruits and less vegetables, how does that reduce the incidence of colon cancer? Is it that there are these chronic inflammation that occurs in the bowel? Is it that there are more carcinogens in certain foods? Those are cancer-causing substances, and just the bowel wall is exposed to it more. Do those have a higher chance of causing a polyp to form? Why exactly do those things play a role in increasing the risk of colon cancer?
Yes, that's a great question, Nasser, and I think it's multifactorial. It is part directly related to what you're ingesting, and then part indirectly through probably the microbiome and the products that the microbiome produces. And that's the area that we don't have a lot of knowledge right now, but it's creeping along and we will eventually understand better. But some of the breakdown products, especially of red meat, that cause not just cancer, but they contribute to coronary disease as well. And usually the threshold for that is 5 or more servings a week. That is what has been best linked to colorectal cancer. I don't know the data on coronary disease, but that's best linked to colon cancer. So it's a
Yeah.
combination of direct and indirect mechanisms.
And this idea of the microbiome, which some may or may not be familiar, we have literally trillions of bacteria that live with us in our body. They live all over our skin and in our oral cavities and in our GI tract. And you can study the bacterial content of your stool and get a sense for what your microbiome is. And you can alter your microbiome. In fact, we have seen this for decades with antibiotics. You give somebody antibiotics, and you can actually induce diarrhea or induce infections that inflame the bowel. So can you tell us a little bit more about what we do and don't know about the microbiome as it relates to colon cancer?
Certainly, we know about associations between certain species and colorectal cancer. We see different distributions of the microbiome in people with colon cancer versus those without. But what we're not sure about is what happens over time. So it could be that this association has occurred, this association between colon cancer and the microbiome has occurred as a consequence of having the cancer rather than as a cause for the cancer. Now, it makes more sense that it would be a cause or contribute to the cancer, but we really haven't established that very well, or how long that distribution of different microbes has to persist to, to result in neoplastic growth. And I want to pick up on something you mentioned before. very often it is through the pathway of chronic inflammation. There have been studies in mice who were made obese to adjust for the effect of body weight, who were fed ultra-processed foods. And it was found that after a certain amount of ultra-processed food intake, that there was inflammation in the colon and there began to be sort of pre-neoplastic changes in some of the cells. And this has been implicated more so for early onset colon cancer, where, we're seeing cancer, increasingly prevalent in people under age 50. And there's also a cohort effect, meaning that, over time, it looks like exposure to certain lifestyle factors has moved with that generation of person and somehow has contributed to their risk. The last thing is that you'd also mention antibiotics. Antibiotic exposure early in life has been linked to early onset colon cancer, although again, the linkage is very tenuous because there's so many other factors that intervene that contribute to risk. And even though these research studies adjust for everything they can measure, they don't adjust for what they can't measure.
Yeah. And I think just to expand a little bit on this notion of inflammation, inflammation is a common underlying theme when it comes to many cancers. It's this idea that cells are inflamed, they're damaged, and then a repair has to take place. And as you damage and repair, there's a higher propensity of acquiring DNA alterations. Those cells are just damaged and repairing over and over. We see this with things that cause scarring in the lungs. We see it even with one of the risk factors, for instance, of ovarian cancer. Something we're not talking about today is the number of what we call ovulatory cycles. The more ovulatory cycles an egg undergoes, the higher the likelihood is that one would get ovarian cancer. So this is a very powerful theme in many different cancers. As it relates to lung cancer, everyone is very familiar with cigarette smoking. And cigarette smoking causes tremendous chronic inflammation in the lungs, in the airways, in the throat. And that is one of the mechanisms. But there are about 60 known carcinogens, cancer-causing chemicals, that are in a cigarette. And it's thought that it takes about 3 or so cigarettes to induce a new mutation in the DNA of cells that are exposed to that cigarette smoke. Secondhand smoke, in other words, inhaling somebody else's smoke, contains those very same carcinogens. And it's as if you are smoking yourself, particularly if you're in close proximity to somebody who is a long-time cigarette smoker. And so we know that firsthand smoke and that secondhand smoke are the major risk factors for lung cancer. Having said that, there are large populations of people who get lung cancer who have never smoked a cigarette in their life and who don't live with somebody who smokes cigarette, and they don't work in a workplace with people who smoke cigarettes. And they too can get lung cancer. We say that anyone with lungs can get lung cancer. And so the risk factors go way beyond cigarette smoking. For instance, radon, which is a radioactive substance that is in high concentrations in the soil, is a risk factor for lung cancer. And many homes in Indiana, particularly in their basements, have high levels of radon. So this chronic exposure to radon can cause lung cancer. We know that in certain populations that are chronically exposed to cooking fumes without ventilation, that's a risk factor. Air pollution is a risk factor. Asbestos. There are a number of occupations that put one at high risk for lung cancer. That includes welders and pipe fitters and machinists, many factory workers, many military exposures. So there's this myriad of risk factors for lung cancer. Now, one of the things that we notice in our lung cancer population is that there is a cohort which tend to get lung cancer at a younger age. They tend to have mutations in certain genes that trigger a normal cell to becoming a cancer cell. My understanding is we are seeing a similar shift in colon cancer. And to the point where even the guidelines for when you should screen somebody for colon cancer is at a lower age. Can you talk a little bit about this pattern that has been observed, and why you think that's happening, and then what we can do to maybe alter that new reality?
Sure. Well, it seems that the lowest risk cohort for colon cancer was born sometime around the mid 50s, mid 1950s. And since that time, successive cohorts have seen higher risk of colon cancer and occurring at earlier ages, suggesting that not genetics, but something in the environment has contributed to that increase in risk. There is a lot of research that has been published and ongoing to try to identify those risk factors and also how to use them in a quantitative way to perhaps start screening certain people before even the age of 45. Now, having said this, we've seen a slow increase, and it's been gradual increase in the risk of colon cancer. Back in 2000, 7 to 8% of all the colorectal cancers occurred in people under age 50. Now it's 11 to 12%. So in a little more than a 20-year period, that risk has increased almost 50%, going from 7 to 8% to 11 to 12%. So it's up a fair amount. And I don't think we quite understand the reasons why. Again, it's thought to be not genetic, but either phenotypic, so life exposure kind of things that I mentioned earlier, or an interaction between phenotype and genotype. That is still being investigated. But the factors that keep turning up are sedentary lifestyle, BMI, cigarette smoking. So these are not terribly different than for older people. It's just that their contribution to risk may be greater in a younger population.
Is there anything that is different about the colon cancer? Is it in a younger person? Is it worse? Is it more likely to be on the left side versus the right side of the colon? Is there something inherently different, or is it simply the same cancer that happens at a younger age?
Yeah, good question. Well, the relative contribution of genetic causes is going to be greater at younger ages. So things like the hereditary non-polyposis syndrome, the Lynch syndrome, or the polyposis syndromes, you expect earlier onset disease. But what we're seeing now with the increase in early onset colon cancer is an earlier onset of the typical colon cancers. They are 75% of the time on the left side of the colon or in the rectum. So they're distal cancers that are, picked up with, even sigmoidoscopy will be able to detect those. That distribution looks like it's a little bit higher in men. And in men, it's also more likely to be in the rectum than in the colon. So the increase that we're seeing in early onset colon cancer, meaning now under age 50 is more rectal than colon, and it's higher in men than women in general. So that's what we're seeing. It's more typical of the same kind of cancer, the sporadic cancers that we're seeing in people who are 50 years of age and older.
We talked a little bit about the role of inflammation, and I know that chronic inflammation in the colon is a risk factor, and we see this in people who have ulcerative colitis and Crohn's disease. Can you talk a little bit more about the genetics and family history with it relates to colon cancer? Are there other cancers outside of colon cancer where a family history might make you concerned that they may also be at risk for colon cancer, and just any of the other risk factors that we haven't talked about yet?
Certainly. So when it comes to family history of colon cancer, obviously the most significant risk factor is having one or more first-degree relatives with colon cancer. And especially if one of those first-degree relatives is younger than the age of 60. So the so-called high-risk family history is having two or more first-degree relatives with colon cancer, irrespective of age, or having one who's younger than 60. Second-degree relatives don't contribute to a person's risk unless there is a first-degree relative with colon cancer. And first-degree relatives who develop it later in life, meaning like after the age of 70 to 75, probably contribute little, if anything, to a person's risk. So having said that, there are other cancers that should grab the attention of people and certainly primary care providers for hereditary syndromes. And those would include uterine cancers in women. That's a Lynch syndrome cancer. So are rare small bowel cancers, Lynch syndrome cancers, cancers of the pancreas. So a GI cancer other than colorectal should trigger some, asking about family history, trying to uncover whether there's a possible HNPCC or a Lynch syndrome going on. And there are online calculators that primary care docs can use that they put the relative in, the age of the relative, the cancer, and it will give a risk for whether genetic testing should be done in that patient in front of you. And it always helps to have the cancer available in the relative who's had cancer to know whether it was a sporadic cancer or if it was possibly a mismatch repair defect generated cancer.
Yeah, I want to expand a little bit on this notion of family history. So knowing your family history is really important. And that's not just about cancer, but it's the other medical conditions that run in your family. Because while cancer can result from environmental exposure or lifestyle factors, there also can be a major genetic component. It's not always an inherited defect in a gene that causes cancer. Sometimes it could be alterations in genes that metabolize carcinogens, for instance. So I think it is really important to know your family history, and your first degree families, as you mentioned, are the key. It's good to know second degree and third degree, but first degree, and that means your parents, your siblings, and your children. As it relates to cancer in men, this is obviously very important for colorectal cancer. It's also important for lung cancer. Your risk of lung cancer is higher if one of your parents or siblings or maybe children had a diagnosis of lung cancer themselves. So it is important to know that. This is also true for prostate cancer. In fact, there are linkages with certain genetic alterations that can actually hit pancreatic cancers, for instance. and prostate cancers, or even breast cancer in families and prostate cancer. So knowing if somebody in your family had breast cancer actually would be relevant to you. It's possible that you have something called a BRCA2 mutation, and that is a risk factor for developing prostate cancer. Um, I think knowing the genetics are really important. Knowing your risk factors are really important. You started off this conversation by talking about primary prevention and secondary prevention. I think we've discussed primary prevention, which is largely don't smoke, don't drink, exercise, weight control, what you put in your bodies, healthy foods, non-processed, low red meat, high fiber, fruits and vegetables. Can you talk to us about secondary prevention? What does that
Sure.
mean?
So secondary prevention involves getting screened. So feeling well, being asymptomatic, not having any of the worrisome symptoms of cancer, and still submitting to testing. And that testing can be either, right now, it can be stool-based, blood-based, or endoscopy-based. Um, there are other tests as well that are available. They're not as widely available, such as CT colonography, which is basically a CAT scan with a very detailed machine that takes very fine cuts through a person's abdominal cavity and then uses specialized software to reconstruct what the colon looks like. It's got a very cool name, virtual colonoscopy, because it reproduces what the colon looks like without actually putting a scope into the colon. But it's not widely available. It requires as vigorous a prep, if not more so, than having a colonoscopy. And there are nuisance findings that cause a lot of worry to clinicians and patients, the so-called incidental findings, hepatic cysts, renal cysts. Occasionally, it picks up another cancer that's curable. So it's a mixed bag. The thing is, it's not widely available and largely not reimbursed as a primary test for screening. So having eliminated that, we can talk about the stool tests, which there's a fecal immunochemical test where a small specimen is collected and it's processed for human hemoglobin. And when that content surpasses a certain threshold, it's determined to be positive. If that's the case, then colonoscopy is warranted to find the source, and that is recommended to be done on an every year basis. In European countries and in Canada, they're done every other year, and the thresholds for these tests vary from country to country. But the fecal immunochemical test is the most common test used worldwide to screen people for colorectal cancer. The other stool-based test currently available is the multi-target stool DNA test, which is known commercially as Cologuard, and more recently now as Cologuard Plus, the new version of the test that is improved in its ability to detect colon cancer with a lower false positive rate. That's a combination of looking at, again, the stool for blood, as well as certain signals of mutated DNA that might be concerning for a neoplasm being present in the colon, either a cancer or precancerous polyp. Recently approved is a blood test for colon cancer that has reasonable sensitivity and reasonable specificity. However, it is not as good as any of the other tests out there. It is more costly. At this point, the interval for the test has not been clarified whether it would need to be done every 3 years or every year. And anyone who should consider getting screened would consider any other test before doing the blood test, which I would consider a test of last resort for those who absolutely refuse to do any other test under any other condition. And then we get to the endoscopies, flexible sigmoidoscopy is used to examine the left side of the colon. And the left side can sometimes mirror what will be seen in the rest of the colon, or it's predictable based on what's on the left side, but not always. So it's an incomplete exam of the colon. Having a negative sigmoidoscopy does not ensure a normal rest of the colon, especially in women, especially as they get older. And in early onset, it would be a particularly fruitful test because, again, most of those cancers and precancerous polyps are on the left side of the colon in younger people. And then finally, there's the most popular test, the one that's used most commonly in the US, which is colonoscopy, which examines the entire colon and rectum. And we all know about colonoscopy. It is omnipresent. It requires a vigorous prep, bringing a driver, sedation, with the ability to tolerate conscious sedation. Some people do have it unsedated, but it's the single best test. It's one-stop shopping, diagnosis and treatment in one session. It is the most sensitive test for detecting precancerous polyps, which is probably the most prevalent way that we secondarily prevent colon cancer. So all those tests do both early detection and prevention, but the breakdown of what they do varies based on what the different test is. The stool tests do mostly early detection of cancer. Colonoscopy and sigmoidoscopy do mostly prevention through the detection and removal of precancerous polyps. That starts at age 45 for average risk people without that high-risk family history that we discussed earlier.
Do the stool tests help you determine who may have polyps that should undergo a colonoscopy? Or is it purely detecting the potential that they have cancer? Because the way I thought about it with colonoscopy is that you obviously can directly visualize whether somebody has cancer, but you can also and would remove polyps. And what percentage of people with colon cancer have it arising from polyps?
Yeah, that's a good question. It's believed that really most cancers arise from polyps. They go through what's called the adenoma carcinoma sequence, where you start with a small polyp that may have a mutation, and over years that polyp starts to have other mutations in other genes, which further promotes its growth. So it goes from being a small polyp to a larger polyp, and then more mutations have it progress from that larger polyp into an invasive cancer. The timeline for that progression is ill-defined. It's thought to be long, meaning 10 years, maybe longer. That's the sort of traditional pathway. There's an alternative pathway, the serrated polyp pathway, which is thought to take less time. But again, we don't really know this all that well. But it entails a different series of mutations, the serrated pathway, that can lead to colon cancer more quickly, but again, does so through the mechanism of polyps. It's pretty unusual that you'd get a cancer arising, just de novo without passing through some precancerous phase. And, to come back to your question, the FIT tests and the stool DNA tests don't do as well a job in the detection of these precancerous polyps, even the advanced ones. But over time, because of repeat testing, if those polyps continue to grow, at some point they are going to bleed, such that reapplication of these tests, especially the FIT tests on an annual basis, is more likely to detect them when they get to a size where detecting them is still considered preventive. And you can go in there and find it.
Yeah, and I want to just make a mention here of lung cancer, and I want to get back to some of the things that you've talked about here. So, I believe colon cancer is the second most common cause of cancer death in men. Lung cancer is the most common cause of cancer death in men, and lung screening does help save lives. While about 70% or so of eligible people do get their colon cancer screenings, and about those same numbers get their breast cancer screening, only about 15% get their lung cancer screening. And lung cancer screening is incredibly easy. It doesn't require any preparation. There is no IV. You can keep your clothes on. You can eat and drink even moments before the scan. And you lie in a CT scanner that gives you low doses of radiation, about 25% of the dose of radiation that a diagnostic CT scan would give you. And it takes about 3 minutes to do. And this starts at the age of 50, and it's done annually up to the age of 77. Obviously, if you have abnormal findings, you get, those things worked up. 1 out of 7 people who is eligible for lung screening will be diagnosed with lung cancer in their lifetime. And the reason why lung cancer is the number one cause of cancer death in men and in women, by the way, isn't because it's a worse cancer. It's not a worse cancer than breast cancer in women or colon cancer. It's just that the vast majority of people are diagnosed with it already being stage 4 disease. And that's because early stage disease doesn't typically cause any symptoms. But if you undergo lung screening and you're found to have lung cancer, there's about a 60% chance it'll be found as stage 1, and about a 70% chance it'll be found as stage 1 or stage 2. And those are both highly curable stages. So it's absolutely imperative that we increase our lung screening rates. And at IU, I think we've been doing a good job at investing in what we need to do to dramatically increase those screening rates. I kind of want to circle back with a couple of just big questions. If we had improved diets, weight loss and exercise, avoided smoking and drinking, and did regular colon cancer screening, could we eliminate the death from colon cancer or get really close?
Yeah, I mean, it's a great question. I would say we would reduce it by 80% or more, the incidence and the mortality.
So this is all within our capacity to do it.
I think it is. I do.
Yeah, and I think we could reduce lung cancer deaths by well over 90%. And we know this because lung cancer used to be a rare cause of cancer death up until the 20th century when the deaths began to skyrocket. Now, the good news is it is starting to go down. Our focus today has been on men, and June being Men's Health Month. I wanted to ask you just kind of a broad question. Do you have any advice for women or other loved ones in the lives of men in terms of encouraging them to take charge of their health?
Yeah, I would say to the women, encourage gently. I think the encouragement can function like a Starling curve does. A little bit of it may not be enough. Too much of it may be too much, and will end up just discouraging where the sort of the hearing mechanism turns off. But I think the right amount of encouragement, and I would count on the women to know how much the men in their lives, how much encouragement to present to them. The other thing, it could be useful to get men in your man's life involved with helping, get that loved one to seek screening. So, if there's a men's club, if there's a golfing buddy, talk to that person about enlisting them, trying to get the husband or the brother or whomever screened.
Yeah, and my answer to my own question would be very similar to yours, and I would just add to that loved ones and partners and spouses, we all sort of go through this life together. We're one another's partners and our truth tellers. And I think the best thing that you can do is to yourself live a healthy lifestyle and to exercise yourself and to not smoke and to drink in moderation and to exercise regularly and to share meals with one another that are low in processed foods, that are low in red meat, that are higher in grains and fiber and so forth. And I think if you're sharing the same meals and the same habits and the same lifestyle, it sort of rubs off on one another. One of the things that I've seen, which is terribly difficult, is if somebody wants to quit smoking, for instance, but their spouse continues to smoke, even though that spouse who smokes encourages the other person to quit, it becomes incredibly difficult when the environment that they're in continues to be that same environment. Would you agree with that?
Absolutely. Lifestyle changes are always easier when you can partner with somebody.
Yeah. Well, our time has gone by much, much too fast. I think we've just scratched the surface of what we could talk about. But I'd like to thank you, Dr. Imperiale, for joining me in this conversation. And for those that are listening, I'd like to thank you for joining us for this month's Simon Says. And you can find a recording of today's session and information about upcoming sessions at cancer.iu.edu/Simon Says. And with that, we'll say goodbye and enjoy the rest of your day.
Oh, thanks for the opportunity.